So this is your threats to oxygenation, Unit 5. And we're going to go right into chest pain and acute coronary syndrome. So I did briefly explain about atherosclerosis in the review. So this is just more review for you, but it's, everybody knows atherosclerosis is deposits of fat that harden with age, and they become a plaque and then possible lesion that can slough off and cause a thrombus. Even though we've got a lot of advances in treatment, MI still remains the leading cause of death in coronary artery disease. There's still people dying at young ages. My dad died when he was 49 of a massive heart attack. I was just reading on social media the other day, a friend of a friend's family member died 45 of a massive heart attack. I mean, so people are still dying, even though we're really, pushing the preventative medicine and everything. It still remains the leading cause of death for coronary artery disease. So what are our risk factors? Again, this is review your modifiable and non-modifiable. And the reason why I'm listing this so much is because you need to know it, right? If I've listed it twice in 2 different places, this is a need to know, not a good to know. So I would definitely know the differences. What's modifiable and what's non-modifiable. So you can modify your lipid levels with medications. Hypertension, you can modify it as long as you're compliant with medications. Tobaccoism and drugs, you need to stop. If you are high risk for CAD or if you have CAD, definitely discontinue use of those things. My dad was a smoker and he did drugs, so he did different drugs, but he did do drugs. So that's probably led to him dying at an early age. Activity level. We have pushed prevention and wellness and exercise, but if you're sedentary, then it's modifiable to increase your activity. Obesity, lose weight, diabetes, be compliant with your medications, and that can be modifiable. And then your psychological stress, again, stress is a big problem in everything, not just nursing school, right? The world is more stressed. We are more stressed these days. So your body cannot stay in that fight or flight all the time. So stress management is definitely a huge need and can be modifiable. And then your non-modifiable: age, gender, ethnicity, family history, and genetics. And there are studies out there that gender is modifiable, but most of the time it's the hormones and things that can contribute to the non-modifiable risk of it. So, coronary artery disease, patho. CAD is progressive, right? It's a progressive disease. You're not just going to wake up all of a sudden. My dad didn't just all of a sudden have CAD, 49 years old. No, it was something that was gradual. He just ignored it, or he went and had checkups, but it was missed, I guess. But probably partly, I'm sure, a lot of his fault too. So it is a progressive disease, but once it's symptomatic, the disease is advanced. Like I said in one of my videos, they have done studies and it's shown that people in their teens, the fatty deposits are starting to build up in people in their teens by age 15. It says it in your book. By age 15, they are noticing these fatty streaks. But what 15-year-old, right, goes and gets checked for this? Not many, right? They're not going to go say, I need a diagnostic cath at age 15, right? No. But that's what they're finding out. So your fatty streak develops, and then you get the fibrous plaque. And once endothelial injury takes place, these lipoproteins transport cholesterol into the arterial intima. So then you get the narrowing of the arteries. Your vessel narrows because you've got that plaque that's being inside the vein, inside the artery. They say these usually appear in coronary arteries by age 30. They increase with age. And then you've got your complicated lesion. So this is like the progression, right? Starts off as just a fatty streak, then a plaque, and then a complicated lesion. Well, you've got this plaque, number 2, what always goes to foreign objects? Platelets, right? So number 3 is your complicated lesion. So as your fibrous plaque grows and gets bigger, you get some inflammation there. And your platelets kind of aggregate around that, and it can break off and create a thrombus, or rupture and create a thrombus. All right, so this is just your picture of your collateral circulation. Our bodies are amazing, so if it's not getting enough oxygen, well, the vessels will anastomose and kind of grow together so that you can get oxygen, so the heart can get oxygen. So these are just arterial anastomosis or connections. So your first one, A, is a normal flow. Got a normal flow there. B is your narrowed flow. So that yellow on the sides is considered like the plaque or atherosclerosis. And then you've got your C, which is completely blocked there, but you've got those anastomosis around it that are creating a blood supply that can carry oxygen. So if you look at C, these people might be having some chest pain, right? I mean, they are getting some oxygen, but it's decreased. Look at the difference in the size of the vessels. So these are tiny over here on the side, and this big, huge one's all blocked. So C may be having some intermittent chest pain, things like that. So you got blocked but collaterals on the sides. Blocked but collaterals. BT. Yeah. Oh yeah, you can't read that, can you? Yeah, so this says blocked but collateral. So you got your collaterals right here. So that is your collateral circulation. It definitely, our bodies do try to compensate and continue to live normal lives. So how are we going to prevent this? What are we going to try to do? Now, we're talking about CAD, coronary artery disease. So your disease are these fatty deposits, right? So we want prevention.
Exercise.
Yes. Yeah. So, what do you think, since my father died at an early age, what do you think my doctor is doing? Yes. I'm getting checked about every 6 months to every year. So, she's wanting me to exercise. And, of course, I don't smoke, so I have that going for me. But she's also talking to me about diet. She wants me to cut back on my meats, my red meat, and increase my exercise. What else do you think what kind of labs do you think she's looking at? Cholesterol. What are the two big ones? Triglycerides. HDL and LDL. Right. She also checked my hemoglobin A1C the last time, and it was great. Okay. So the HDL is your high density. That's your good cholesterol, right? And your LDL is your low density cholesterols. Those are your, yeah. What'd you say? Lazy?
Lazy bad.
Yeah. Those are your bad ones.
So does the doctor think that it's hereditary?
Yeah.
You know the lifestyle that your father did?
Yeah. Okay. So, diet and exercise, health history, family history, values and beliefs. What do you think about values and beliefs?
Keeps them stressed.
Right. Right. Us Southerners, like I was born in the South, we eat a lot of fried foods, right? So they've got to talk to us about, like, what do you eat? Sometimes you just got to ask your patients, what do you eat? Because, you know, your idea of what's healthy and their idea of what's healthy might be different. So that's really important. Genetic testing, they're doing all kinds of testing now. That they can tell if you're more prone. I haven't had that done. But they are doing that. And then as far as drug therapy, what kind of medicine do you think my doctor's threatening to put me on?
Statin.
Statin, exactly. So statins are huge. What do you need to monitor with statins? This is a review. What? Huh?
The non-productive.
That's ACE inhibitors.
I think muscle.
Rhabdo, right? You're monitoring. Right. Rhabdomyolysis. Mylosis. So you're monitoring, though, they're what labs are associated with the liver? Yeah, AST, ALT, and then so what's something they might complain of if they're getting some kind of rhabdo? Muscle aches, right? So when your patient's on statins, they need to have liver enzyme tests. They need to, and you need to monitor for muscle aches. Another thing they'll often give is niacin. They may give fibric acid derivatives, depending on, I think those are more geared towards triglycerides and increasing your HDLs. And then your bile acid sequestrants, they sometimes... They will also put people on antiplatelet therapy, like aspirin and Plavix. Because if you go back and you look back at the progression, you've got the platelets that are aggregating that complicated lesion. So your aspirin and your Plavix and your antiplatelets will keep the, what does it do? It keeps everything kind of slick in there, right? Keeps stuff from aggregating. It's an platelet aggregate. So, that is also some drug therapy. That's with CAD. So we're still on CAD. We're trying to prevent this heart attack, right? We're trying to prevent the STEMI. All right. So now we're at chest pain. So what is angina or angina, depending on how you say it? So it's your O2 demand is greater than your O2 supply, basically. And you get some ischemia. So you get some chest pain, lack of oxygen, decreased oxygen. So your demand is greater than your supply, and it usually occurs when your arteries are blocked 75% or more. I said usually. There's so many different cases out there. And everybody knows the word hypoxia is just lack of oxygen, right? But if you have some blocked arteries greater than 75% or more, the patient can become hypoxic. So why does this happen? Well, the narrowing of the arteries causes insufficient blood flow. And it's progressive, as we've already established. But once that complicated lesion, thrombosis, it can be emergent. So let's talk about chronic stable angina. This is your patient with intermittent chest pain. They got the same pattern, usually, duration, intensity. Every time I go cut my grass, I have chest pain. I sit down and it goes away. You don't even have to write this if you don't want to. This ST segment depression or T-wave inversion, I would not try to memorize all that.
Okay.
You need to know ST elevation, and we'll talk about that when we get to it. But I wouldn't try to memorize all these other little things. It's often controlled with drugs. What drug do you think controls this?
Nitroglycerin.
Nitroglycerin, yep. So these patients are not usually having pain at rest, right? And they're at rest. They're usually up doing something. They climb 2 flights of stairs. They cut their grass. They walk their dog. They get chest pain. And that's why it's called chronic, because it's something that's ongoing. And often they'll have the little bottles of nitro that they put under their tongue, and it gets better. They can even take it like prophylactically. Like, I know I'm going to have chest pain when I cut my grass, and they take a nitro. So it's controlled with drugs. And these are just some pictures. It's right from your book. These are just some pictures that that people have chest pain. Now, a lot of times you'll hear people say it's like a pressure. It's like a squeezing. It's rarely sharp or stabbing. It's more like a squeeze, like a pressure, like somebody squeezing it. You will hear people say indigestion, epigastric. The jaws, the neck sometimes. So these are just some different places. At various locations can occur. And then just to review some of this, as far as chronic angina, you've got your nocturnal, which just happens at night, but not necessarily during sleep. Then your angina decubitus, chest pain that occurs when lying down. Silent ischemia just occurs in the absence of any subjective symptoms. These are all good to know, not need to know. I'd be familiar with Prinzmetal's because that is just a spasm of a major coronary artery, and it can occur with or without CAD. So it's really not precipitated by any kind of increase or demand. And then your microvascular is just chest pain that occurs usually without coronary atherosclerosis, a lot of times in women, and it's just abnormalities of the coronary microcirculation, and it's considered microvascular, so it's just the tiny capillary vessels. And so as far as our goals for our patients, our chest pain patients, nitrates, we already established that, right? Nitroglycerin. Often they're on the short-acting type, the ones, they put under their tongue, little nitro tabs, and then it just dilates the vessels, right? So it opens it up so more blood can get out in there, get through, so more oxygen can get through. Because remember I said it's a decreased supply and demand. So your goal is to increase supply. That's our goal, and that's what it does. By opening up those vessels, you get an increased oxygen supply. They usually say if no relief, call EMS. They can repeat it up to 3 times. And we already established that they can use it prophylactically. Occasionally, they'll be given long-acting nitrates as well. And who can tell me some of those? Does anybody know what some long-acting ones are? Yes, Amdur, isosorbide. Sometimes a nitroglycerin patch that they wear. They can wear it.
They have Procardia, which is the nitroglycerin tablet.
Sometimes they give the Procardia. And then our side effects of our nitroglycerin. Headache. And sometimes our blood pressure will go down. But what is the most prevalent side effect is the headache, right? Because it dilates the vessels, you get a headache. Definitely you're watching their blood pressure. But that's kind of what we want it to do. If everything's got bigger pipes to go through, then you're going to have a lower blood pressure. That's expected, right? If you got bigger pipes, you're going to have a lower blood pressure because you got more flow. So less peripheral resistance with bigger pipes. So you're going to have a lower blood pressure. That's expected. You will sometimes, though, your doctor will say if it drops below 80, don't hold the next dose or whatever. You'll have some parameters there, but that is kind of the expectation. And also orthostatic hypotension because of the lower blood pressure. So that is an expectation, and the headaches definitely is a true side effect. Now, as far as medicines, your ACE inhibitors are definitely antiplatelets, aspirins. They may be on just a regular baby aspirin. They may be on Ecotrin or a coated aspirin so they don't get upset stomach, right? So your ACE inhibitors is definitely a collaborative care. Your beta blockers. So your ACE inhibitors decrease blood volume, decrease preload and afterload, and decrease blood pressure. Your ACEs are often prils or your ARBs, and your ARBs are usually given if the ones that can't tolerate the ACE inhibitors. So what are the side effects for your ACE inhibitors? Right, the cough, and then what else can they get that could be angioedema, where they're swollen, you know? So they may not be able to tolerate the ACE inhibitors, and they may have to try an ARB on them. And then also, they help prevent ventricular remodeling. So if someone's had a heart attack, it helps prevent ventricular remodeling. Who knows what that is, ventricular remodeling?
It's when our heart muscles try to fix themselves, but
Right.
they don't do it quite right, so they don't pump right anymore.
Right, so it's just basically scar tissue that, and the heart tries to correct it, but there's still some scar tissue there. And then your beta blockers, your ARBs are often sartan, and then sartan, S-A-R-T-A-N. And your beta blockers are LOLs, L-O-Ls, right? So your beta blockers decrease heart rate. That is your first primary thing they do. They will decrease the blood pressure, but that's secondary because what are they doing? They're blocking that sympathetic response, right? So they are beta blockers. They decrease the heart rate, therefore decrease the blood pressure. So hypotension is possible with them. They also decrease the O2 demand because they decrease the heart rate.
Sorry.
So then your calcium channel blockers decrease your blood pressure and your systemic vascular resistance. Those are your pines and your Zim. Y'all know that little funny little saying? Lumberjack Zim took the pines to the mill. It's your calcium channel blockers. And then here's your sodium current inhibitor. That usually is given for sometimes when your other anti-anginals don't work. I think it and then we already talked about our meds to decrease cholesterol, but this is redundant, but it's collaborative care, right? It's like, what are we doing for these patients? What needs to be done as far as medications for our patients with cardiovascular disease? Because we're doing what? We're trying to keep them from having a heart attack, right? So we're wanting to be proactive and prevent the progression of the atherosclerosis into a complicated lesion, right? So we're trying. This is part of our preventative. This is part of trying to prevent a cardiac event. Our collaborative care. And then, of course, there's all kinds of tests. You get a patient with chest pain. They're going to go for probably stress test. Of course, they're going to get an EKG. They're definitely going to probably do a chest x-ray and an echo on them. And then as far as they'll do an exercise stress test if they're able to walk good. And then sometimes they'll do a nuclear one if they don't feel like they can get on the treadmill. That's part of the nuclear. Yeah. They inject them with, I think it's called thallium, and it makes their heart go fast. It's like or adenosine. It makes their heart go fast, and they then they look to see if they're having problems. So all of these are just some possible diagnostics with your patient coming in for chest pain. And then they might even do a diagnostic cardiac cath. When I used to work with a lot of heart patients, they sometimes would come in for just a diagnostic. It wasn't emergent. They had a scheduled cardiac cath. And they went up to check their arteries, visualize, see if they had any blockages. Sometimes they didn't even have a positive troponin, and they just had a scheduled cardiac cath. But if there is a blockage, it can open blockage. It can be interventional. So it can visualize, so it can be diagnostic, and then it can be interventional. When you say interventional, that just means they might need to do something like a balloon or a stent. So PCI is percutaneous coronary intervention, and they use a balloon angioplasty. You can see a picture right here. This is a balloon, and then they left the stent because there was some need there. And then this is the last slide for this one. It's just a progression. We're going to get right into ACS, acute coronary syndrome. So you've got your coronary artery disease, and then your chronic stable angina. We just talked about that. But it can turn into acute coronary syndrome. So it can turn into a problem. But your acute coronary syndrome includes your unstable angina, your non-STEMI, and your STEMI. So this right here is important. So that's your acute coronary syndrome. We're going to go right into that because I think that's the end of it. I'm going to give you a quick break and then we'll resume.